Anesthetics were developed out of the need for more humane surgery. The ideal agent causes loss of sensation and consciousness, amnesia, and relaxation of skeletal muscles. Anesthetics can either be inhalational or intravenous. They must cross the blood-brain barrier, either by diffusion as a lipid-soluble molecule or through active transport. And the potency of an inhaled anesthetic is expressed in minimum alveolar concentration, or MAC. The MAC is defined as the concentration of a drug that induces anesthesia in 50% of patients. It's analogous to the ED50 concept, or the median effective dose, which you learned about in pharmacology. Another important concept is the solubility of drugs in blood. The more soluble the drug is, the more that must be given in order to produce a change in the partial pressure of gas in blood. Now, what drives gas from blood to brain? Well, it's the partial pressure. So, the less soluble the drug is, the quicker the partial pressure rises, and you have a more rapid induction of anesthesia. The potency of an anesthetic also correlates with its lipid solubility. The more lipid soluble, the more it is able to cross the lipid membrane. Thus, the higher the lipid solubility, the more potent the drug, and since less is needed, this is inversely related to the MAC. The rate of induction is also influenced by the alveolar ventilation. Let's think about things that affect the respiratory rate. People who were pre-medicated with benzodiazepines or opioids have decreased ventilation rates, thus lower alveolar ventilation, so it takes longer to induce anesthesia. Patients who have emphysema or atelectasis have more dead space, so in those patients it will also take longer to induce anesthesia. Now, inhalational anesthetics pass through the lungs into blood, and the blood next travels to the brain. When cardiac output increases, more blood passes through the lung parenchyma while receiving the same amount of anesthetic, so the gas becomes more dilute in the blood, and thus the partial pressure in the blood is reduced. This would also increase the time to induce anesthesia. Now we'll discuss the inhaled anesthetics. Although these drugs have been used for years, the mechanism remains unknown. Most of these anesthetics are sufficiently potent to induce surgical anesthesia, nitrous oxide being the exception. It's not potent enough to produce surgical anesthesia by itself, but it potentiates other anesthetics, so it's commonly used in combination with other drugs. The choice of inhaled anesthetic depends on the additional effects, such as how much hypotension they cause, or the degree of skeletal muscle relaxation. It may also depend on the safety of gas. Some gases are too flammable to be used safely. All inhalational anesthetics depress respiratory rate, depress the force of myocardial contraction, and frequently cause nausea and vomiting in patients once they've woken up. Antiemetics are commonly prescribed in the postoperative period because of this. Now, most of the anesthetic is eliminated simply by breathing, but small amounts are metabolized by the liver and kidney. Now, halothane hepatitis occurs in about 1 in 15,000 patients. Methoxyflurane is metabolized into free fluoride ions in the liver, and these are actually nephrotoxic. And rarely, nitrous oxide can diffuse into air-filled cavities in the body, causing pneumothorax, obstructed intestine, air emboli in the bloodstream, etc. And we're going to discuss malignant hyperthermia in a few moments in the dantrolene fact. Intravenous anesthesia is more rapid, smoother, and more pleasant for the patient, since inhaled anesthetics are often malodorous. Now, do you recall on which receptor the barbiturates and benzodiazepines act? That's right, they act at the GABA receptor, which opens the chloride ion channel. We've already discussed the side effects of these drugs, which you definitely want to know. Now, ketamine is a drug that blocks neuronal excitation by acting at the phencyclidine site gated by an NMDA glutamate receptor. Ketamine is also special because it may produce hypnotic or dissociative effects on the CNS and amnesia. Afterwards, it may cause bad dreams in adults. Now, the opioids like fentanyl and its derivatives are commonly used, and I'm sure you know their mechanism of action. That's right, they act at the mu receptor. Then we have propofol. Propofol is really the most commonly used anesthetic. And what's the mechanism of action? Well, it potentiates GABA, and it also inhibits NMDA glutamate receptor activation. It's popular because it is short-acting, meaning that it only takes about 30 to 50 seconds from injection to put the patient under. Also, once you've stopped the medication, the patient will wake up within 5 to 10 minutes. Compare that to midazolam, which takes about 2 to 3 minutes to induce anesthesia. Not all surgeries require general anesthesia and completely knocking the patient out. For instance, most office procedures, excision of a mole, many dental extraction procedures, things like a lumbar puncture, etc. In these procedures, doctors prefer to use local anesthetics, such as lidocaine. The effect of the local anesthetic depends, of course, on where it is injected. They block voltage-gated sodium channels, hence preventing action potentials from reaching the CNS. They're not specific to nociceptors, but rather act on all the neurons, sensory, motor, autonomic neurons. It's probably not that high yield to spend your time memorizing the different classes of local anesthetic, for example, esters and amides, primary, secondary, tertiary. Just know that they're classified because they differ in their half-life and metabolic products. Local anesthetics block the smaller diameter myelinated fibers first. Thus, B and A delta are blocked first, and then C fibers. The pain fibers are A delta and C fibers. A delta are for fast pain, and C fibers are for slow pain. Then you lose A gamma fibers, which produces a flaccid paralysis. The A beta are lost last, and those are the ones mediating touch and pressure. Thus, B and A delta fibers are blocked first, and then C fibers. A delta are the fast pain fibers, whereas C fibers are the slow pain fibers. Then you lose A gamma fibers, which produces a flaccid paralysis. A beta are lost last, and those are the ones mediating touch and pressure. Local anesthetics are commonly given with epinephrine to enhance their local effects. What does the epinephrine do? Well, it causes vasoconstriction, so by decreasing the amount of blood flow to the area, you're decreasing the washout of the anesthetic. Cocaine is naturally vasoconstricting and is sometimes given in these situations. Now, if patients are allergic, most commonly they might be allergic to esters, like procaine, then you should give amide drugs, or you can premedicate using antihistamines such as diphenhydramine, also known as Benadryl. As far as side effects, these drugs are usually pretty safe when given correctly. It's said they can lower the seizure threshold, so you should be careful and perhaps give benzodiazepines in patients with that propensity. However, they can cause arrhythmias, particularly upon accidental injection into the bloodstream rather than the local area. Bupivacaine is the most cardiotoxic of the locals. Lidocaine can be used therapeutically in certain arrhythmias. As we mentioned, these are sodium channel blockers, and you can learn more about that function in the cardiology lectures. Now let's discuss the neuromuscular blocking drugs. These drugs are used to relax skeletal muscle, most commonly during surgery. They are classified as either depolarizing or non-depolarizing. To understand the difference, we'll just talk quickly about the way neurotransmitters are released. First, action potentials travel down from the presynaptic terminal. At the nerve terminal, the sodium influx opens calcium channels. The calcium opens the channels at the presynaptic membrane, allowing the synaptic vesicles that are filled with acetylcholine to release their contents into the synaptic cleft. Acetylcholine diffuses across the synaptic cleft and binds to the nicotinic receptors at the motor end plate. This binding can be blocked competitively by non-depolarizing neuromuscular blockers. These are agents like curare that bind at the nicotinic receptor but do not cause depolarization of the motor end plate. The effect of curare derivatives can be overcome by using acetylcholinesterase inhibitors. Acetylcholinesterase inhibitors act to increase the amount of acetylcholine at the cleft, so the increased amount of acetylcholine actually overpowers the curare. Now, the binding of acetylcholine can also be blocked by depolarizing agents like succinylcholine, which occupy and activate the nicotinic receptors. Once these receptors are activated, calcium is released at the motor end plate and causes muscle contraction. Normally, the acetylcholine dissociates and then the membrane repolarizes. Unlike acetylcholine, the succinylcholine is not metabolized by acetylcholinesterase, so it stays at the receptor for a long time. Thus, phase 1 block is the time when the membrane is depolarized for such a long time that it's unresponsive to further stimuli. Initially, there's some muscle fasciculation, but eventually this results in flaccid paralysis due to resequestration of calcium by the sarcoplasmic reticulum. Phase 2 occurs with continued exposure to succinylcholine. The membrane repolarizes but is desensitized, so it's not responsive. Phase 1 and 2 differ in their response to acetylcholinesterase inhibitors. Phase 1 flaccid paralysis is intensified by acetylcholinesterase inhibitors. And Phase 2, when the succinylcholine begins to disappear from the synaptic cleft, may occasionally be reversed by anticholinesterase agents. But the response to these drugs is unpredictable and should only be undertaken with great caution. Malignant hyperthermia occurs in patients with a genetic susceptibility, so make sure you ask about family history before any surgery. Classically, it is triggered by succinylcholine, but any depolarizing neuromuscular blocking agent can elicit this response. The heat is produced by sustained contraction of the muscles due to a genetic mutation causing failure of the sarcoplasmic reticulum to resequester calcium. The sustained calcium in the muscle causes continued association of the actin and myosin filaments. Dantrolene is the treatment for malignant hyperthermia as it prevents further release of calcium.